Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The purpose of this podcast is to educate and inform. This is not a substitute for medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.
Hello, my name is Doug Johnson. I'm an Associate Professor of Medicine and leader of the Melanoma Program at Vanderbilt-Ingram Cancer Center. Today we compare two patient cases that relate to stopping of anti-PD-1 therapy and consideration of whether to retreat patients that have metastatic melanoma. These two cases have similarities, yet the recommended treatments may be different. Let's look at the cases. Patient case 1. Our first patient case is Dave. Dave is a 62-year-old man with metastatic melanoma involving the lungs and liver. He was treated with single-agent nivolumab, and he had decreasing size of one of his lung metastases, but had increasing liver metastases when his first CT scan was performed. Since his melanoma has a BRAF V600E mutation, he was switched to BRAF and MEK inhibitors, which were later followed by progression at 12 months on therapy. Patient case 2. Our second patient case is Rachel. Rachel's a 55-year-old woman with metastatic BRAF wild-type melanoma involving the lungs and liver as well. She receives pembrolizumab with a complete response, and therapy is stopped after 15 months of treatment. 2 years later, she has growth of two of her lung lesions, and a biopsy confirms that this is melanoma. So questions for consideration. As you can see, both cases involve progression on anti-PD-1 therapy, but there are some differences. The differences lead your choice of treatment in a different direction, or would both patients receive the same treatment? In particular, would you consider anti-PD-1 retreatment for either or both of these patients? Some background. A standard treatment for metastatic melanoma, regardless of BRAF mutation status, is anti-PD-1 monotherapy, either with nivolumab or pembrolizumab. Approximately 45% of patients experience complete responses to treatment, many of which are durable. Many patients with complete or near complete responses have a discussion with their oncologist and elect to stop treatment after 1 to 2 years on therapy. However, about 1/3 of patients who have a response ultimately experience disease progression. Treatments who either respond to anti-PD-1 and then later progress, or patients who never respond at all is an important issue to consider. Options for these patients include ipilimumab monotherapy, ipilimumab in combination with nivolumab, or if BRAF mutated, BRAF and MEK inhibitor therapy. Retreatment with anti-PD-1 may be an option as well. Other melanoma therapies have shown benefit with retreatment with this type of strategy. For example, patients retreated with BRAF and MEK inhibitors, provided they took at least a 6-week break off therapy, have nearly a 50% response rate to retreatment. In addition, patients who benefited from ipilimumab, then later progressed, had at least a 20% response rate to retreatment. So how are these cases related? Both patients experienced progression either on or following anti-PD-1 treatment. However, there are some key differences as well. Patient 1 progressed while still receiving treatment, and at least his liver lesions never responded to therapy at all. On the other hand, patient 2 experienced progression a long interval after completing treatment. She also had an objective response, in fact a complete response, to her initial course of therapy. So what should we do with these patients? Well, the answer from my perspective is patient 1 should not receive retreatment with anti-PD-1 therapy. A recent publication by Dr. Bedoff and colleagues in JCO studied 396 patients with long-term follow-up following anti-PD-1 treatment. This included 34 patients who were retreated. None of the patients who initially progressed on therapy, so those who didn't have a complete response or prolonged stable disease, none of those patients experienced long-term benefit with retreatment. On the other hand, these patients did benefit from ipilimumab and nivolumab 25% of the time with a 25% response rate. Additional patients also experienced stable disease in this group. Thus, either ipilimumab and nivolumab or ipilimumab monotherapy should be considered for patient 1. Patient 2, by contrast, had a durable complete response to therapy and progressed after completion of treatment. This patient could consider retreatment with anti-PD-1. A study by Dr. Warner suggested that of patients in this position, those who had an initial objective response to treatment, only 15% of patients had objective responses. However, durable benefit was more frequently seen in patients who had complete or partial response to their initial course. Many patients had prolonged stable disease with retreatment. Thus, retreatment could be considered in this patient, or it would also be reasonable to think about ipilimumab and nivolumab combination, or ipilimumab alone. That would also be appropriate for this patient. In closing, thank you for listening to this week's episode of ASCO eLearning Weekly Podcast. For more information on treatment for metastatic melanoma, including additional patient cases and opportunities for self-evaluation, visit the Comprehensive eLearning Center at elearning.asco.org. Thank you.
Thank you for listening to this week's episode of the ASCO eLearning Weekly Podcast. To make us part of your weekly routine, click subscribe. Let us know what you think by leaving a review. For more information, visit the Comprehensive eLearning Center at elearning.asco.org.